We know that immunotherapies have been used for some time now, but that generally speaking, when used as single agents, we don't see the types of effects we want. Most patients don't respond, don't have lasting tumor effects. And so the field is moving towards the combination of treatments. We chose to target two different points within the cancer immunity cycle, both the presentation of antigens and the activation and priming of T cells. These two treatments, agonistic anti-CD40 monoclonal antibody and tremelimumab, work in combination to activate T cells to provide a tumor response.
Because the whole idea of the checkpoint blockade is to take the brakes off the immunity, but you've been doing not only that, but also putting the accelerator on as well.
You're absolutely right. We like to say that we're stepping on the gas while cutting the brakes. And we hope that using these combinations, using these treatments together, will provide enough impetus to the immune system to overcome the immunosuppressive microenvironment of the tumor.
How much evidence was there that the anti-CD40 would do that, put on the accelerator?
So we've been studying anti-CD40 for about a decade, both as a single agent and in combination with chemotherapy. And in each of those studies, we've seen a response rate of somewhere between 20 and 25%. Also, we've seen activity in the serological biomarkers, specifically peripheral blood mononuclear cells. We've seen evidence of immune activation. So we knew there was a signal there. And so we thought that when combining it with a CTLA-4 antagonist like tremelimumab, we may get more long-term responses. And so far that's what we've seen.
And why tremelimumab and not ipilimumab, for example?
Well, for practical reasons. At the time of the study, both agents were owned by a Pfizer company, and so it was a simple combination to make.
What did you do in the study then?
So we enrolled 24 patients, and we treated them every 12 weeks with tremelimumab and every 3 weeks with agonistic anti-CD40 monoclonal antibody. Patients tolerated the treatment well, and again, we had an overall response rate of 27%, which was very exciting.
27% overall response rate. What about survival?
So the overall survival is 26.1 months with a progression-free survival of only three months.
And this was a cohort of patients with metastatic melanoma. Anything else to say about them apart from that?
So these patients were relatively heavily pretreated. 70% of the patients had had previous treatment with a median of one treatment within the group, and they did well.
Well, this overall survival of 26.1, were there any within that who are living a lot longer?
Absolutely. We have one patient in particular who is alive now 3 years after starting the study, and she received no additional treatment. We have seen patients who responded and then progressed on our trial go on to receive PD-1 therapy and do extremely well. So there seems to be a signal for the combination of these drugs with the PD-1 blockade antibodies.
You were doing a double therapy. Did that mean twice the toxicity?
No, actually. Surprisingly, we saw very similar toxicities to what was seen in the single agent studies. One thing that should be noted is that the threshold for toxicity was lowered a little bit in the tremelimumab. So when tremelimumab was studied as a single agent, the maximum tolerated dose was 15 milligrams per kilogram IV every 12 weeks. In our study, that threshold was lowered to 10 milligrams per kilogram. However, the overall toxicity rate was very similar.
Of course, in the last few years, we've heard pretty interesting results coming from ipilimumab. How do these compare, the results you're getting here?
So I think the results here are very favorable. So when compared to either ipilimumab as a single agent or tremelimumab, the addition of the CD40 agonist seems to really improve the overall response rate. When you look back at the single agent tremi and ipi studies, the overall response rate was somewhere around 10%. Now we've more than doubled that in this study.
What do you think doctors will be able to do with this in practical terms then?
So I think this combination hopefully will go on to see phase 2 and phase 3 studies take place. And I think we'll be able to slot this alongside therapies like PD-1 as part of our armamentarium against malignant melanoma and other malignancies.